BC here. Welcome to BC Nephro. Thanks for watching. Today I'm going to talk about another cause of nephrotic syndrome, another cause of glomeruloproteinuria, focal segmental glomerulosclerosis, FSGS. Now, in this condition, it is more common than minimal change disease, more likely to progress, at least in adults, more likely to progress to chronic kidney disease, end-stage kidney disease requiring dialysis, more resistant to treatment, an important condition in adult nephrology. One thing that's very important to know, and one thing that's kind of interesting, at least I think it's interesting about this condition that we'll talk about. The first is deducing what the underlying cause of FSGS is, and the second is the tsetse fly. So in any event, focal segmental glomerulosclerosis means part of some of the glomeruli are scarred. Now, scarring is not a disease. Scarring is a pathologic description. We're going to need to find out what the underlying disease process is that caused this scarring in order to decide how to treat. In all of them, the podocytes are damaged, causing the proteinuria. We're going to figure out what's going on. So the first thing I'm going to talk about is primary or idiopathic FSGS. Now, this is like minimal change disease, but worse. It causes scarring, more resistant to treatment, postulated to be caused by a circulating immune factor, which causes damage to the podocytes. Now, it's important to figure this out because since it's caused by a circulating immune factor, then immunosuppression is warranted. And you're going to tell this because, like I said, it presents as a full nephrotic syndrome similar to minimal change. On biopsy, in addition to the scarring that you're going to see, diffuse foot process effacement as in minimal change disease. So you have the full-blown nephrotic syndrome, diffuse foot process effacement, you're thinking primary idiopathic FSGS, and you're thinking treatment with immunosuppression. Now, if you read in the text or the online articles, they're going to recommend, the guidelines are going to recommend high-dose steroids as initial treatment like for minimal change disease. In my experience, I like to jump straight to calcineurin inhibitors, cyclosporin, tacrolimus with low-dose steroids for this condition because in my experience, the necessary treatment for high-dose steroids is too long, longer than 2 months, up to 4 months. Not a good idea. More side effects. Jump straight to the cyclosporin and tacrolimus-based regimen. Now, the second is going to be secondary FSGS. Now, secondary FSGS is going to be caused by viruses, medications or drugs, or hemodynamic strain, which is called adaptive FSGS. Now, for secondary causes of FSGS, the treatment is going to be to target the underlying cause, of course. An important consideration is going to be this adaptive FSGS, this hemodynamic FSGS, which is very common in obesity and obstructive sleep apnea, or commonly seen in these conditions, commonly seen in obesity and obstructive sleep apnea. So you're going to tell this because these patients have proteinuria, which may be nephrotic, but they don't really have the nephrotic syndrome. They don't have severe edema. They don't have severe hypoalbuminemia. So that's how you're going to tell clinically. And on biopsy, you may see glomerulomegaly, and the foot process effusion is going to be more likely to be focal than diffuse. So if you see this stuff going on, if you find a medication or a virus, you treat that. HIV is one of the secondary causes of viral FSGS. But if you see this adaptive hemodynamic strain, you're not going to put them on steroids or other immunosuppressions. Not a good idea. You're going to treat their blood pressure. You're going to use ACE inhibitors or angiotensin blockers to try to keep the protein down. The third thing you're going to see is genetic FSGS. So a lot of these genetic things are congenital nephrotic syndrome, and you may not see as adults. But there are several genes that you will see as adults. And one of the cool things, getting into the tsetse fly, is they've discovered a mutation called APOL1, APOL1, and they discovered this mutation. There's a risk factor gene, kidney disease, including FSGS, that's very common in people of African descent. So what's the deal here? So African sleeping sickness, which is caused by the tsetse fly, a trypanosome infection, and the APOL1 is the immune defense to get to this infection and getting the African sleeping sickness. So trypanosomes developed a kind of resistance to the normal APOL1. So people developed a resistance to that. So there's these APOL1 mutations that are protective against that. And if you're homozygous, got one of them, you're good. But if you have two bad disease genes, you have a higher incidence of different types of kidney disease including FSGS. And this gene is very common in people of African descent. Apparently 13% have at least one of these mutations. One of the underlying explanations for the higher incidence of kidney disease seen in African Americans. Now, the fourth bucket we're going to talk about is really burnt out glomerular disease. So there's some other glomerular disease that happened in the past, burnt everything out, caused scarring. And again, this is something that may have severe proteinuria, less likely to have nephrotic syndrome. When you look at the biopsy, you're going to see not only scarring in the glomeruli, but you're going to see a lot of scarring in the tubular interstitium. Treating these people with immunosuppression, not a good idea. You're going to treat them with blood pressure control, ACE inhibitors or angiotensin blockers, and things like this. So a little bit of the detective work here. Put the clinical picture together with the pathological picture to figure out whether it's primary idiopathic FSGS, secondary FSGS, genetic cause, so you're looking at a family history there, or if it's a burnt out glomerular disease. Again, if you do you like this topic? If you like this topic, let me know below. If you want to hear other topies, if you want to hear more about dialysis, electrolytes, acid base, let me know in the comments below. Send me an email at brian@bcnephro.com. Link to an article with more details about this at bcnephro.com. And until next time.